But let's take a look at the cardiovascular risk reduction in prediabetes and diabetes. What have we learned about this risk reduction and how we approach it and how we think about it? Rosemarie, where do you start with that?
So I guess now we have the availability with all these new agents of modifying risk. And I think we should start actually in the pre-diabetic state. And obviously, I believe that we are in the golden days of diabetes management. And with all the extra glycemic impacts, you have the potential of have a different narrative, a paradigm shift in the way we treat our patients.
Okay.
I think, again, what questions do we have? Well, again, all these studies had a finite number of events, at which point things stop, but we'd like to see what happens long term.
Well, let me fine-tune this a little bit more, because you're talking about starting in the pre-diabetes period, which goes to your whole point earlier about this is all a smoldering issue before you know what's going on. In that context, are we going to change the way we define pre-diabetes? Are you pre-diabetic? Not knowing anything about your medical history.
Well, we're all pre-death.
That's my point. In other words, where I'm going with this is, you want to start giving statins to people who have diabetes, irregardless, I'm not sure that's a word, regardless of knowing or not knowing their lipid levels. Does everybody deserve to be considered in some regard in the United States pre-diabetic?
So we're not there yet, but I do think it's a moving target. Where we define diabetes, obviously, is a moving target, and maybe what we say now is prediabetes is actually really diabetes. We just don't know.
Yeah, and I think, Stephen, you mentioned this. It's very abnormal glucose metabolism well before you hit a hemoglobin A1C of 7.
Of 7, right.
So I think that's an
not
arbitrary
normal.
threshold, right? These drugs have adverse, especially the insulins and the sulfonylureas, they had adverse events. You want to pick a robust target well above, where things go awry, because you have a drug that has harm. If these drugs have the benefit that they're purported, will you back that up even further?
What we're doing right now is mopping up the floor. Do we want to turn off the faucet?
Well,
I remember the day when the thresholds for diabetes went from a fasting blood sugar of 140 to 126. It was a huge concern. Oh my God, we're over-treating everybody. I think to your point, we're looking at a continuum, and we aren't there yet. I think treating pre-diabetes, particularly with metformin, makes sense, but it's not done and may not be covered, even though it's a pretty cheap medication. So I think we need to change our orientation to, just like we did with lipids, is that the difference between a blood sugar of 125 and 127 really doesn't make that much of a difference.
And we know for the atherosclerosis part, the atherosclerosis process is starting well before these patients hit a hemoglobin A1C of 7.
Which is where I was
Absolutely.
going.
Absolutely.
I mean, if you can get, if I understood you correctly, it has little to no effect on their glycemic levels, some of these drugs.
Yeah, the
So-
risk,
A little bit.
when not combined with insulin or sulfonylurea, and please my endocrinology colleagues, that the risk of hypoglycemia is very minimal with these drugs, especially if you were going to use it as monotherapy or on top of
So let me put this
metformin
on the
and
table
Right.
without any proof, right? We're talking in the future now, proof
Off-label,
TBA,
yeah.
TBD. I've got somebody who lives in the United States. We know the cardiovascular risk, all comers. We know the diabetes risk, all comers. We know the diet. We know what people are like. Statins, a lot of people are taking statins. And if I'm not taking a concomitant hypoglycemic agent, but taking some of these other drugs will dramatically reduce my cardiovascular risk, does it make sense in the future that we'll start giving these people, this drug to people, all comers, whether or not their sugars, their A1Cs are abnormal or not?
So remember, these trials were all done with people at very high risk
Right.
and diabetes. So if we're going to start to say that, we have to do the trials in people who don't have diabetes or don't have cardiovascular risk.
Right. I mean,
So
it's
in the future, those are the
science-driven.
trials you want to see.
We have to see the trials
have to see
before
it.
we can make that decision.
But I would say, Peter, I think, get away from the diabetes management, the hypoglycemia. And I've heard, and I'm interested with Karol says, I've heard my cardiology colleagues, if you told me I have a drug that could reduce the risk of heart failure by somewhere to 30 to 50%, with the epidemic of heart failure, would that be something that you would think about starting just for that benefit alone?
That's where
And
I was
and
going.
We all would.
Right.
That's why they're doing
Yeah.
the trial.
That's where I was going with it.
I think that is definitely where the field is moving, but I agree, sort of in the absence of data, it's hard to recommend that, but that's where it
We are
is.
not recommending starting these drugs tomorrow.
But what I do think we have to, right now, all the trials are known cardiovascular disease plus diabetes.
Right.
We have to do these trials in diabetes, no known cardiovascular disease. Because let's be frank, the difference between diabetes and cardiovascular disease and no cardiovascular disease is one bad day.
Yeah, and these patients, right, a lot of them actually have coronary disease, they're just
don't know.
They don't
diagnosed, so
know
they're
it.
not
As
truly
I said, we don't have the
negative, right?
marker. Right.
That's what I was getting at. What I heard from all of you is this disease has been smoldering for a very long time.
Absolutely.
And the markers that we've used have been imprecise, blunt instruments. So if we were to say that somebody, all of us perhaps have this process to some degree or another, and that all comers, all comers with these studies, we reduce their heart failure rate, their death rate, their cardiovascular disease rate with these medications. Can you foresee a day where these are just tonics? They're not diabetes medicines, they're tonics. You take them.
And that day will come if
you
the
do
data
tri-
supports it.
Exactly. You gotta do the trials.
Because it's exciting to think about the possibilities, but we're, at the end of the day, we're
So-
science-driven.